Patients with chest pain suggestive of angina pectoris generally undergo invasive coronary angiography and revascularization if feasible. Threshold for coronary angiography may vary from region to region depending on the availability of resources. Non-invasive testing in the form of treadmill exercise ECG or sometimes a nuclear imaging stress test or stress echocardiography may be done prior to the coronary angiography to look for evidence of inducible ischemia. But these tests are neither 100% sensitive nor specific. Computed tomographic CT coronary angiogram is another modality which is considered prior to invasive coronary angiography in the recent era. The DISCHARGE Trial Group compared the two as the initial strategy in a study published in the New England Journal of Medicine on March 4, 2022. It was a randomized trial comparing CT coronary angiography and invasive coronary angiography as initial diagnostic strategies for guiding treatment of persons with stable chest pain and an intermediate pretest probability of obstructive coronary artery disease. The study was done across 26 European centers. Primary outcome assessed was major adverse cardiovascular events of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke over 3.5 years of follow-up. Main secondary outcomes noted were procedure-related complications and angina pectoris. Complete follow-up could be obtained from 3,523 of the 3,561 study patients. Major procedure-related complications occurred in 0.5% of the CT coronary angiography group and 1.9% of the invasive coronary angiography group. Angina during the final 4 weeks of follow-up was reported in 8.8% of the CT group and 7.5% in the invasive coronary angiography group. Major adverse cardiovascular events occurred in 2.1% of the CT group and 3% of the invasive group. Authors concluded that in the intermediate pretest probability group, the risk of major adverse cardiovascular events was similar in both groups. Major procedure-related complications were lower in the initial CT strategy. An accompanying editorial pointed out certain issues with the trial. There were only limited number of patients with high-risk anatomy who would benefit from revascularization. 13.9% in the CT group and 11.2% in the initial invasive coronary angiography group. Pretest probability cutoff for the trial was 10 to 60% in this trial. More than 35% had non-anginal chest pain, 37.4% in the CT group and 36.2% in the invasive group. These two trial design features could have led to the observation that only a quarter of the patients had obstructive coronary artery disease with luminal narrowing of 50% or more. This might suggest that the trial group was actually low risk rather than intermediate risk. The editorial author also pointed out that ACC/AHA guidelines published in 2021 does not recommend testing in the low risk group. CT-based fractional flow reserve FFRCT and quantification of plaque burden and lesion characteristics might improve the accuracy of prediction. It may be noted that many lesions leading to acute coronary events are not flow limiting before plaque activation. Here are the first set of references. Second set of references. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.